Swayam Prabha. Digital India. Educated India.
Welcome back. In lecture 47, we will talk about healthcare facility standards. This is the second part of the lecture. So, the concepts that we will cover are the 2022 IPHS guidelines, then IPHS guidelines in regards to district and sub-district hospitals, then guidelines in regards to community health centers, then for health and wellness centers, primary health centers, and finally we will do gap analysis. So, the 2022 IPHS guidelines, these are prepared, as you understand that we have discussed about the earlier guidelines, this health standard guidelines for India, this was last revised in 2022, but with the but after Corona and also after the national health policy has been set up, has been proposed, has been drafted in 2017. So after that, and also after Corona, after this pandemic, the government has realized the lot of inadequacies in our healthcare system and so on. So the new guidelines have come up in the year 2022, this particular year, and using this guide, so this suggests a lot of changes in the way healthcare has to be provided in urban areas, and these are the new standards which should be followed when determining how much healthcare facilities has to be provided in urban areas, or what kind of healthcare facilities has to be provided in urban areas. So these are prepared following this new guidelines are prepared following a target-based and outcome-oriented approach. So that is, at the end of the day, there has to be some targets and there has to be some outcome. So all the the guidelines are decided in such a way so that at the end we can reach some goal, and not an input based and normative approach to reach underserviced areas. So we have got figures and a general idea about where some services are there, not there, so that is fine. So earlier we used to give services over there, but now it is more about, for different areas we can have different targets, and we have to achieve targets for different areas, and accordingly we should provide the services. Now, delivery of services through public health sector, again we are not talking about private health sector, we are talking about public health sector. So it follows the three-tier structure as we have discussed earlier, which was suggested earlier in the National Health Mission. And so here you can see that the three-tier structure is primary healthcare facilities, secondary healthcare facilities, or tertiary healthcare facilities, or healthcare services you can talk about. So this tertiary, secondary and primary, the same categorization we will maintain for also creating our standards. So again, the standards are now has to be created for both rural and urban areas, because we have talked about both the national rural mission as well as the urban health missions, right? So we have to have standards for both areas. Then we have to have standards for infrastructure, health workers, drugs, equipment, health information system, and finances, which are all required for running this kind of healthcare services. But anyway, we are not going in details about infrastructure or the number of health workers or what kind of drug should be available. So if you are interested, you can go into the detailed standards and you can study that. In the references, we have listed the name of those standards and all. But at the same point of time, we are mostly concerned about what number of beds, what kind of facilities, how many of those facilities has to be provided in urban areas. So all these inputs regarding infrastructure, health workers, even though we are only concerned with one aspect of it, but all these inputs has to be combined to provide quality health services. So we are not only talking about provision of infrastructure or facilities, we are also talking about provision of health services. Earlier, we used to set up a hospital and people used to, or a primary health center, and people are supposed to come and meet there. But now we are mostly focusing on community we are also focusing on community outreach, where we have to reach the people. We have to reach, and then there are referral system from the lower community level. People may come to the primary center. From primary center, they may be referred to higher order tertiary facilities as well. So that means it's an integrated healthcare approach, provision approach, and that can be only possible, and overall this entire system design is possible when all these aspects are looked together. So for provision of services, all these inputs are combined, but at the same point of time, when we talk about facilities and all, we would be mostly focusing on the number of facilities, number of beds, and how much area has to be reserved for those kind of facilities. Health services should be equitable, accessible, affordable, and responsive to the needs of the population. So that is as per following national policy on healthcare provision. Now the new guidelines, unlike the last guidelines, now talks about also four kinds of, earlier it was four categories of facilities. Here also we talk about four categories of facilities, but there are some changes. For example, the first category is district hospitals and sub-district hospitals. So this is the highest order facility, or you can say it's a secondary order facilities, or maybe some case it could be also referred to as a tertiary facility also. Say it is a secondary order facility. Other medical colleges and all these things are tertiary order facilities. Whereas the next order is the community health center, which is CHC, for both has to be present in rural and urban areas. So this is, you can say this is sometimes the primary care facility. Health and wellness centers, under that it's a primary health center, PHC, which has to be present in both rural and urban areas. And there is also multi-speciality which are also facilities, which are also known as polyclinics. These are known as UPHCs, and these are mostly for urban areas, like urban primary health center. So these are primary health center, these are community health centers. So sometimes the community health center can be the first referral point or the first primary healthcare provision, but usually we start at the more bottom level, where we have primary health centers, and above that we have the community health centers, which provide higher order services. And below the primary health centers, there are sub health centers, and these again could be provided in rural areas, which is and also urban areas, where these are known as urban health and wellness center, and rural areas these are known as this sub health center, this health and wellness center. So that's the terminology people are using now. So this is health. So instead of just health centers, we are adding the term wellness. That means we are not only looking into standard healthcare provision, but also we are trying to promote other kinds of healthcare provision, which actually improves the overall wellness of an individual. So that's why these are known as health and wellness centers. But these are at sub-health centers, primary health centers, and then there are community health centers. So these are the different hierarchy that has been created. Now coming to how we interpret these guidelines, right? Or how we actually determine what number of facilities, what kind of facilities has to be provided. So as per the 1946 Bhor Committee report, it was said that in India, we require 1 bed for every 1,000 population. So this is the minimum amount of beds required per population. But the problem is, even though this is the minimum bed required and it has been, recommended in the year 1946, till now many states have not been able to achieve this. So the current guidelines state that this 1 bed per every 1,000 population is the essential number of bed, or the bare minimum number of beds that has to be provided. Whereas the National Health Policy 2017 refers to, it says that we require around 2 beds per 1,000 population. So obviously this is double than the number of beds that was suggested earlier. Now why this is suggested? Because many areas of the country is growing overall, affluence is growing, our affordability is growing, healthcare cost, also healthcare provision is changing. So, and also there is growth in the healthcare market to a large extent. Now, the problem is not all areas have growing in the same pace, and at the same point of time, while there are some areas which is not able to, grow, at this particular pace, but there are other areas which has grown beyond. So for there, the higher order requirement could be decided, and we are saying that these are the desirable levels of facilities. So this is the bare essential, and this is what is desired. That is what should be maximum we can provide, right? So this is what is desired, which should have been better. So so this is the basis for creating of this new IPHS guidelines. So we will give essential as well as desirable figures for different kind of healthcare facilities. Now coming to the way we decide or how many beds has to be provided for an urban area or for any area for that matters. Usually it was based on the assumption that for a particular, and because we are talking about different kinds of we should start with a district level, and we say that within a district, based on the number of population, we have to determine what number of beds has to be provided. So the normative district population, or you can say average, is something around 19 lakhs, but the normative one is 20 lakhs as per census 2011. So based on this particular figure of population, we can say that at least 2,000 inpatient hospital beds are required. So these are inpatient hospital beds. We will define what are inpatient hospital beds later on. But 2,000 of them are required, which is essential. But of course, we are now also talking about desired as well. So that means where the desired is 4,000 beds. So for each district, there should be at least 2,000 beds which should be available. So how this should be provided? It should be provided based on many criteria. It should be based through many facilities, right? But actual number, what should be provided depends on many factors, right? How will you distribute these facilities in a particular area? So that depends on the actual population and the distribution of that population in that area. The local epidemiology, that means what sort of diseases are happening, where it is spreading, which location it is happening. So based on that, we can determine burden of disease, depending on the cost of disease, which diseases, what is leading to what sort of mortality, morbidity, what sort of cost. So based on that, we can decide on what kind of facilities should be provided to treat what kind of diseases and so on. Then overall community requirements, health seeking behavior of the population, what sort of facilities people want, and the contribution of the private sector. That means what sort of facilities the private sector is coming up with, because the people will also try to make profit by running this as a business. So of course they will come out with certain kinds of facilities. So the government can consider that while deciding on what it should provide, right? So these are the different factors which it can consider while deciding how many public health facilities or how many public beds has to be provided, or where these public beds has to be provided. So the district action plans are created where health facilities are mapped as per their type and level of service they provide. So in a district, there could be different kinds of healthcare facilities, and those are mapped based on what kind of services are available and what quality of service they are providing, and based on that, people can determine where to go and what to go for what kind of disease, or if it's a higher order, what sort of infrastructure is provided there. Based on that, they can go there. So now we come to the actual guidelines, which is the first set of guidelines is for districts and sub-district hospitals. Now, essential number of beds in a district. So we are talking about essential and desired number of beds. So essential number of beds should come from public health tertiary care, which are medical colleges, secondary care facilities, which are district hospitals, sub-district hospitals, some community health centers. Then primary care facilities, some primary care facilities may have some beds provisions in them, so that some of them can be considered as well. So usually the total number of beds are added up by adding up the beds in each of these particular facilities, and this leads to the essential number of beds that are required in a district. So tertiary care facilities cater to people from the entire state and even from outside the state, so should preferably be considered at the end. That means when we are adding up the number of beds, after we add up all primary care, secondary care facilities and all, after that we will consider if some additional beds that should come from tertiary care. So we will try to make up everything from within this secondary care facilities. This could be additional, but if there is lots and lots of beds available in this kind of facilities, then we can also take some beds from there as well. So the desirable number of beds, how do I calculate that? That is not only the essential ones, that is the this kind of facilities that we discussed, but also beds available in the private sector, beds available in railway, armed forces, power grid, coalfields, employee state insurance, and other public sector undertaking hospitals. All these different public sector undertakings run their own hospitals, and this PSU hospitals could be the capacity of PSU hospitals could be added up with the private sector hospitals and other beds, and then adding up with the essential beds that are there, and these together should lead to the desirable number of beds. So that is how, when government should plan for number of beds that should be provided, it should spread it out among this sort of facilities, and we can add the private sector and all the other hospital beds and all, and to see how much this are we able to reach the desired number of facilities. If not, then we can also promote we can facilitate development of other private sector hospitals or health centers or polyclinics and so on. So by beds, what is meant? By beds, it is meant inpatient hospital beds. That is beds available and functioning for more than 24 hours. So that is what our inpatient hospital bed means. So in addition, some critical care beds are also added in that. What is not added are emergency beds in emergency sections of the hospitals or facilities, LDR, dialysis, daycare and pre and post operative beds, which are just for resting and some sort of diagnosis or some sort of healthcare primary ambulatory service that has to be provided on a daily service that has to be provided. Those beds are not considered as inpatient hospital beds. Inpatient hospital beds are the ones where a person can get admitted and can stay beyond 24 hours. So that's why this is how we should decide, or the number of beds should decide what number of facilities, how the beds should be provided. So coming to the actual figures or standards given by the IPHS guidelines, we can see that for population less than 2 lakhs, we require 50 beds plus 15 additional. These are emergency and daycare beds. So this is the extra beds. Desirable beds is around 100, which is just double of that. Between 2 to 5 lakh, 100 beds plus 25 additional, and of course this is double, and so on. Where more than 30 lakhs, it should be 500 beds plus 65 additional beds, and desirable beds is 700. So this is what the number of beds that should be there in different districts of the country. Now, secondary health services for district lesser than 5 lakh population with district hospitals do not require sub-district hospitals. So if a district is of less than 5 lakh population, in that case, if a district hospital is already there, there is no need for other sub-district hospitals. But if a district is more than 5 lakhs, maybe in the range of 5 to 10 lakhs, we can add one subdivisional hospitals or sub-district hospitals. Now additional one, now a district may have got 20, 30 or 40 lakh people residing in that. So that means for every one additional 10 lakh population, we can add on one SDH in addition to whatever is there. So if suppose there are 30 lakh people living in a particular ULB, in that particular case, we will have one district hospital, and then we can have one subdivisional hospital. So that is up to 10 lakh, and then another two sub-district hospital for that extra 20 lakhs. So total we have got 3 SDH and 1 DH for a particular district. So, but that doesn't mean that all the beds that we are proposing over here should be present in this suppose it's a 30 lakh district. So in that case, we have got around 700 beds desirable. So what it means is this hospitals plus primary health centers, community health centers, plus private sector all together will contribute to this 700 beds which is required for that particular district. Now, the next are the standards for community health center, which are again given in this volume 2. I think this is the other, these are guidelines are created in separate volumes of IPHS guidelines. And here we are coming with another term which is FRU, which is known as the first referral unit. That is, from the initial community points, where do you refer for a particular medical emergency, where the patients are referred. So, FRUs, usually these community health centers in rural areas are the first, could be a first referral unit, or it could be a non-first referral unit as well. So, there are two kinds of community health centers which are suggested. One is a FRU and the other is a non-FRU. So, non-FRUs will have 30 essential beds, and essential services include preventive medicine, promotive medicine or services, promotive services, curative services, palliative services and rehabilitative services. Now, what is a preventive service? Preventive service is measures which are taken to prevent the onset of diseases, like immunization programs, and many other things can be come under that. Promotive services are, overall different kinds of programs and all which can be undertaken so that we can promote good health among the people. Curative is for curing certain patients in case of certain diseases and all. Palliative in case of perennial, problems like heart diseases or cancer, then we give palliative care. And rehabilitative services, as you can know, this is self-explanatory. So, in addition to the essential services, curative services are also provided, which include normal deliveries and stabilization of common emergencies. Now, these are for non-FRUs, but in case it acts as a FRU or a first referral unit, that means it is where people are referred to. In that case, in both urban and rural areas, this kind of particular facilities, this not only provide basic services which are given over here, the standard, medical treatment that is provided and some delivery and stabilization can happen. But in addition to that, there is specialized care by specialists could be given, like physicians, surgeons, obstetricians, pediatricians and anesthesiologists could be there in this kind of facilities, and the relative infrastructure which is required for their the different operations and other kinds of handling of emergencies and all, that is different functional operation theatre, blood storage unit, all these things are required so that we can do more complex operations and so on. So as you can understand, this is a basic kind of facility. So, with basic, but still some amount of delivery and all these things can happen, but this is where you can do some sort of operations and all these things. So, this is not a hospital, but it's a second layer of, you can say, facility where some of the hospital services which are provided at the hospital could be also done over here. Both elective and emergency surgical services of secondary level care could be provided in this kind of services, in this kind of facilities. So, this is where, this is how what are community health centers. Now, how do I distribute them? So, for example, in rural areas, this could be either non-FRU CHCs or FRU CHCs. So, in that case, the ratio is flexible. You have to decide, the planners or the decision makers have to decide what has to be the ratio between these two kinds of community health centers. For FRU CHCs, there could be 30-bed facilities where maternity and surgical services, essential ones, can be provided, whereas in case additional ophthalmic, orthopedic, ENT services are provided, which can be said as desirable, then it should be a 50-bed facility. So, non-FRU is, we are not talking about, we are talking about FRU facilities, which are the first referral units. In that case, it could be a 30-bed and a 50-bed facility. Whereas in case of non-FRU, there is no question of beds, because it's mostly direct care that is being curative and other cares that are given. Emergency, we can have some deliveries and all, but that doesn't mean inpatient, this hospitalization, all these things are allowed. In urban areas, for urban community health centers, this number of FRUs are flexible. Why? Because in urban areas, we have got polyclinics, maternity homes, then maybe your SDH and DH is located over here. There could be tertiary medical colleges and so on. So there are a lot of facilities which can provide this kind of services, like this kind of operation and other kinds of services. So that's why there is no need for specialized FRUs. So you are flexible in case these are not that available, like there are not too many private hospitals, there are not any tertiary facility. In that case, we can have some number of FRUs as well, or urban community health centers. In that case, you have to decide on their number, how many of them has to be provided. So if provided, then there can be 50-bed hospitals where maternity and surgical services essential can be provided, where there are 100-bed ones where additional ophthalmic, orthopedic and ENT services can be provided, which are desirable. And these are also provided for metropolitan cities with population more than 1 million. This sort of 100-bed facilities has to be provided. So this is how we have two hierarchies, that is the district and the sub-district hospital, and then we have the community health centers, which are mostly providing this not only basic services but also advanced services such as operations and different kinds of medical treatment of medical emergencies and so on. Now, coming to community health centers at block headquarters, again you see that we are maintaining that hierarchy while planning for this kind of spread of this kind of facilities. Block public health units act as referral units for this health wellness, this primary health centers and this sub health centers at the block, and provide all primary health care like clinical and public health services. So that means all these smaller facilities at the block level can refer to the block level community health center. So that's how you organize the hierarchy, and that's how you organize the different kinds of facilities. So this results in decentralized planning of public health activities, and this can result in effective disease surveillance, forecasting and data reporting can be done from the different data that is being collected, and this could be done at the community health centers at the block level. Now, community health centers in rural areas, in terms of how many has to be provided, one for the standard says 1 for 80,000, particularly in hilly and tribal areas, and 1 for 1,20,000 in case of plains. So for every 1,20,000 people, we can provide one community health center. Now, one community health center at the community development block, taluka, tehsil, circle level. So at least one should be there at the block level, or it's also known as taluka, tehsil or circle, whatever term is being utilized. And as per the 3-tier Panchayati Raj system, this is the block panchayat, gram panchayat and zilla panchayat. So this is the district level, this is the block level. So this community health center aligns with the block level, whereas the district hospital aligns with the zilla level. And gram panchayats are mostly where we talk about this primary health center and this sub health centers. So community health center in urban areas, these are, again we say that these are not, this may not be given, or they can be given, the number of them can be determined based on availability of all other facilities. So this can be provided where, in case of metro cities greater than 5 lakh population, in case of non-metro cities with more than 2.5 lakh population, we can provide this kind of community health centers. Now, this adds to the existing SDH and DH and maybe other tertiary facilities. So these facilities are additions on that. And so we can say that one UCHC at the ward, town or ULB block, city, district level, and this could be a 50-bed or a 100-bed facility as per the population. Like we have discussed that in case the population is more than 5 lakhs, we go for this 100-bed facility, or if 2.5 lakhs, then we can go for a 50-bed facility. So usually, again, you can see similar to over here, where we are providing in the rural area, we are providing one CHC at the block level. Here we are providing one UCHC at the ward level or town level or ULB level, whatever the case may be. Next, we will talk about the health and wellness centers, primary health centers. So there are two kinds of health and wellness center. One is the primary health center and the other is the sub-health center. So in case of primary health centers in rural areas, it should be preferably a 24/7 facility, at least the ones which are conducting deliveries, where deliveries are allowed, there we can have a 24/7 facility. Otherwise, it is not required to be a 24/7 facility. That means only in the daytime people may come, consult with the doctors and then they can go back. They can provide routine care plus some amount of preventive and promotive health interventions as well. So that means it's general curative care plus preventive and promotive health care. So usually the standard says 1 for 20,000 people in hilly and tribal areas and 1 for 30,000 people in plain areas. This again, following the same hierarchy, we will preferably align this primary health center with a panchayat level and this helps in effective convergence of this alignment of the different hierarchies of services, and we can be able to provide citizen centric services at the panchayat level as well. So PHC is linked with a cluster of sub-health centers. So that means here also we can have several sub-health centers linked to a PHC. So that means where some services are not being able to be delivered at this sub-health center, these people can go to the linked PHC and those primary care services could be delivered over there. So this can also act as a FRU, first referral unit, for all linked this sub-health centers. So that means this is the first level of referral. From this level of referral, we can go to the next level of referral, which is the primary health center, and if that also is a problem, we can directly go to we can directly, instead of primary health center, if those facilities are not there, we can directly go to the district hospital and so on. Now, in case of urban primary health center, in this case, these provide routine outpatient outpatient care, and this along with also they can provide preventive and promotive health interventions as well, similar to the rural areas. And there is no need for deliveries because in an urban area the spread is not too much. People we get other kinds of facilities, so no need for presence of delivery facilities over there. And as because of that, there is no need to have any kind of 24/7 facility. But existing facilities which are already doing deliveries in urban areas for this kind of primary health centers, so there we can continue to operate for 24/7 or deliveries can happen. But new centers, there is no need for provision of this kind of beds or deliveries over there. So usually we provide 1 for 50,000 population, and it should be in close proximity to urban slum areas, because the focus is to provide services for urban slums or poor people. Now, there could be some specialist UPHCs, primary health centers or polyclinics, also known as polyclinics. So, this multi-speciality polyclinics are provided for specialist services on ambulatory or daycare, but they are on daycare basis, right? And there is only outpatient care, but these are for specialized services, and usually these are provided for 1 for 2.5 to 3 lakh people, for one facility for 2.5 to 3 lakh people. So you can see that for every 5 or to 6 primary health centers, you can have one multi-speciality center. So that means while for 50,000 we provide one primary health center, we can have for around 2.5 lakh for more population, we can have one extra multi-speciality center. So, and where it should be located, this can be dependent on geographic location, population density, available infrastructure, and so on. Finally, we come to the health and wellness center at the sub-health center level. So, this is the smallest or the basic level service that is being provided. So, this is sub-health centers in rural areas. These are provided 1 for every 5,000 population. That means it is provided in a village. And for hilly or tribal or desert areas, it could be provided for 1 for 3,000 people, because in there the villages are more sparsely populated and so on. So that's why 1 for every 3,000 people. In case of urban areas, and this could be 1 per 15 to 20,000 population, and caters mainly to the poor and vulnerable population residing in slums. So in slum areas or near slum areas or a concentration of slum areas, we can have one of these centers. So As you can see that this guidelines has changed from earlier this IPHS guidelines. So accordingly, we also need to change our URDPFI guidelines, which we have to prepare a new set of URDPFI guidelines where we have to consider this health and wellness in the way we are providing this kind of services, or the calculation of number of beds, how we are going about it. So that has to be really looked into. We have to look into what sort of facilities overall can be and how they can be distributed and so on. And then we have to propose our new guidelines. So that needs to be updated. So these standards can be used for framing a new comprehensive guidelines for provision of urban healthcare services, which can be taken up in in future URDPFI revisions and so on. Now, I will come to another part of it, because when we are planning for this kind or setting this kind of facilities and all, we have already discussed or determining that how many of these facilities has to be provided. So we have discussed something in the second module. We have talked about gap analysis, particularly for provision of social infrastructure services. So this, just to remind you, gap analysis is to determine the current state of infrastructure and services and the desired state as per the projected changes, priorities, financial viability and carrying capacity of an area. So we need to determine how many healthcare facilities are required in the future. Now, on what do we base that? We base that on different things. We will base it on new IPHS guidelines. We can base it on URDPFI guidelines, or maybe the modified URDPFI guidelines we can utilize based on new 2022 IPHS guidelines. We can have new set of URDPFI guidelines. So this will give me the norms and standard that has to be followed. But everything else, like what are my aims and objectives, what does the stakeholders prioritize, different laws and regulations for that urban area, all these things and the different programs and policies that are going on will determine that what should be prioritized, what sort of health centers should be coming up in an area. So along with projections for population, carrying capacity analysis, determining of what is required, financial viability, we determine how much amount of facilities that needs to be provided. So to do that, we need to do current state, we need to understand what is the current state and then what is the gap, what has to be breached or fulfilled. So this current state refers to the current distribution, coverage pattern, technology used, which may have become irrelevant or obsolete. Some technologies are not useful nowadays. Maybe some facility is there, like some kind of x-rays and all, which is now has to be changed and new facilities has to be brought in, right? So that's some intervention that has to be done. Remaining life of infrastructure, equipment, facilities and other things that will be considered when we say that this is the current state of workable state of or things which can be used, and in future this is what we require. So what is the gap? Accordingly, we have to provide those kind of services. So this gap analysis we have discussed in detail earlier, so I'm not going in detail, but what it means is these guidelines that we just learned, including the URDPFI guidelines, are considered as the initial point where we start determining what sort of facilities are required. But that doesn't mean that the final plan that we will prepare for an urban area will have exactly as per these guidelines. It considers many other things into consideration which are given over here, or how these facilities would be distributed at different parts of the city or for which population group. So that has to be analyzed as per that particular local context. So to do that, we can follow some basic rules. One is, of course, the hierarchy of this social infrastructure services. That means we have already learned this earlier, that for higher order facilities, we have already learned the hierarchy already in the guidelines. We were seeing the hierarchy of different kinds of health infrastructure. So we can follow that, but we have to also understand that higher order facilities are actually catering to most number of population, and the top tier facilities are catering to not only my local population but population from surrounding area. So to do that, we have to add some extra capacity to those particular facilities. So around 25% capacity can be added so that we are comfortable with extra surges during certain times, or we can also consider, like in case of more number of people come to one facility, or there is concentration of one facility, maybe that facility has a good reputation, so we have to take some precautions for that. So then the other parameter that we will consider is the proximity. Some facilities has to be provided at the local level so that we can intervene with the community. So in that case, local level facilities should be provided considering non-motorized transportation. So distance is a key rule. So maybe within 5 to 15 minutes walking distance. So it depends on what sort of facility, what is the walking distance, accordingly we can decide. So proximity plays a role. That means physical accessibility of that particular facility. Then participation, if the particular this healthcare sub-health center is supposed to do some community level programs and all, they should be in close proximity to the community where it should do those programs. So that is what participation is all about. Location should consider participation of the community it is designed to serve. Finally, ownership. Some facilities are private, some are government facilities. Now, location choice of these facilities are determined by many factors, which depends as per what kind of service. Is it a primary health center? Is it a district health center, district hospital? So, depending on that, we will decide. Depending on land availability, dependent on location, transportation availability, all this plays a role in determining location choice. Whereas private facilities are developed as a business opportunity in most cases. So they are also like dispensaries, clinics, hospitals. In that case, private individuals decide based on their considerations where should be the location of that facility. Finally, facilities could be also utilized for multiple purposes, and that may also determine their location as well as distribution. So that is how, in addition to the hierarchy of services or as per the standards, we have to consider other aspects as well to determine how we should actually locate these facilities in urban area. So these are the references that you can study. And to conclude, healthcare facility standards for urban areas are defined by the Indian Public Health Standards, and 3 tier of facilities are defined for provision of primary, secondary and tertiary care services. Thank you.